Okay, well, welcome back. I hope you had a nice break. I grabbed some water, so hopefully I won't have the scratchy throat as we get through this next section. So, clinical dilemmas related to tongue thrust. And you probably have already heard some of the dilemmas that I spoke about. A big one that comes up with clients, with patients, is what causes tongue thrust. Everybody wants an answer, and I'll be honest with you, no one has one. There doesn't seem to be any particular cause of tongue thrust. Part of there's many different facets of why this is a complex question. But one of the things that everyone knows, but you may not realize it until I point it out. Everyone tongue thrusts. All infants have a tongue thrust pattern. If you think about that, it makes sense. Infants have very small heads. Their mouth is disproportionately small to their tongue when they are born. And the whole suckling and nursing process is the tongue reaching out and grasping the nipple and creating a suction and nursing. And so that forward tongue protrusion is innate in everyone. Now what happens is as we develop, the tongue begins to float as the head begins to elongate. So most infants have a very round head, and as they develop, it lengthens out. And again, as you're sitting here listening to me, you can visualize the tongue of an infant kind of protruding out of the mouth, always kind of resting in that open position. Again, they have super tiny sinuses as well, so they breathe through their mouth and their nose. As they develop, that tongue floats. It naturally floats along the palate, the roof of the mouth. And so as it floats there, it shapes that palatal arch, and that palatal arch spreads to make room for that tongue. Now again, there's a lot of different theories and bias and philosophies on that. But again, for me, that makes the most sense, because with my tongue thrust patients, what I see is that tongue doesn't float. Why doesn't it float? There's a number of reasons. So the question is, what makes that normal tongue thrust that every single infant goes through turn into an oromyofacial disorder? Tongue thrust is technically considered an oromyofacial disorder. I do not refer to it as such, except for in very exclusive professional circles, because in my opinion, OMD is a much bigger, and like I mentioned earlier, it tends to be syndromes and complex facial anomalies, and tongue thrust doesn't really fit in that. And most of the people that I'm working with, when I say most, I'm talking 99.9% of them, don't want to be terrified about having an oromyofacial disorder. It's a scary sound, and it is very clinical, and we're talking about teenagers who are 14, 15, 16, already self-conscious, and I'm not going to tell them they have an oromyofacial disorder, because they're going to freak right out and not want anything to do with this really effective and pretty rapid intervention that can completely change their orthodontia and their oral patterns and make things just a heck of a lot easier and very cost effective, comparatively speaking. So with my parents, with my patients, I refer to it as tongue thrust. Tongue thrust is simple. Tongue thrust is not, it is classified a disorder, and insurance does cover it because it is a swallowing disorder, but it just doesn't have all the stigma that something as scary as OMD carries. So that is why you'll hear me refer to tongue thrust. I'm not afraid to say tongue thrust. Again, People historically felt like they had to call it OMD in order to get recognition and validation that it actually existed. I just like to keep it simple and practical. It's tongue thrust. So what makes a normal tongue thrust that an infant has become an OMD? A number of things. And it makes sense. Again, if you go back to what I just said about the anatomy and physiology of a developing infant into a toddler, if you have something that is in the mouth so that they are not able to have that tongue float, it will habituate on the floor of the mouth. Okay? The muscles won't develop for that floating effect, and if that floating effect doesn't happen, you're not going to get that nice palatal arch. You're going to have a high vaulted palate. Okay? So one of the contributing factors is just flat out congenital. It's the way the structure is genetically for that child. And I have seen it. I have literally sat in therapy. I have done group therapy with entire families. The mom or the dad, 2 or 3 siblings at a time, because they all have the same structure. And because they all have the same structure, likely they all develop the same habit, right? And this is not a conscious habit that you develop. It's just part of your development. Infants who have feeding problems oftentimes will have swallowing. They'll have a regression. They don't have that same developmental pattern because they don't have the same stimulation. So there are times when that can be a contributing factor. Again, these are all contributing factors, but not necessarily a cause and effect. So if you're sitting there and you're going, oh my gosh, I have a tongue thrust, and you're going, I don't have any of these issues or any of these problems, none of these, I've never had any of them. That happens. I've sat across the diagnostic table from many a patient and parents, and they don't have any contributing factors. It's just how they're wired. One that I see a lot is enlarged tonsils and adenoids. Again, think about it. If the back of your throat is full, if you can't breathe through your nose with allergies or chronic sinus infections, those two, in my opinion, kind of go together. Enlarged tonsils or allergies, they create the same situation, which is an obstructed airway. And if you can't breathe freely through your nose, what are you going to do? We've all experienced a cold, with stuffy sinuses. What happens when you can't breathe through your nose? You breathe through your mouth. And so, if you are a developing child and you can't breathe freely through your nose, you're going to open your mouth. And if you close your mouth, or if you leave your mouth open and you lift your tongue up, if it has that float effect, you're obstructing the airway. You're not going to be able to breathe. So you're going to put your tongue down and you're going to open your mouth because that is survival. Okay? It's going to trump that developmental pattern of floating. Okay? The oral habits. Again, if the tongue is on the floor of the mouth, it will develop that resting posture. So oral habits such as sucking a thumb, a prolonged pacifier or bottle use, sucking on fingers. So I have digit sucking. That just means any of them. It can be a thumb, it can be a finger, it can be a pinky. It can also be chewing on pencils. I've had people who chewed on necklaces, people who chewed on blankets. Anything that's in the mouth that is causing that tongue to be on the floor of the mouth. Okay? So any of these can be a contributing factor because of where it places the mouth, the tongue specifically, in that developmental process. And I don't know at what age it turns into a habituated process. I'll throw my granddaughter under the bus and probably hear it from my daughter, but she's had prolonged binky use. She really was a die-hard binky user well into her 2-year-old years. And she still is, she's only 3, and at 3, they're still in that developmental pattern, but she's definitely has, in my humble clinical, professional, specialized opinion, a very anterior tongue thrust articulation and swallow pattern. So will she develop that and maintain that into her adolescence? Probably. Will she outgrow it? Possibly. You just don't know. And that's why it's not a cause and effect, because not everybody who has infant feeding problems has tongue thrust. Not everybody who sucks their thumbs has tongue thrust. Okay, so that's why it's a contributing factor, but it's not necessarily a cause and effect. I hope that's clear. Here are some of the common characteristics of a tongue thrust. As we mentioned before, the depressed resting posture. That means the tongue laying on the floor of the mouth. Generally, most commonly, it is overflowing those lower teeth. Yeah, that's the best way I can describe it. If you look in the mirror, and if you're just in a resting posture and you open your mouth, where's your tongue? Is it behind your teeth? Is it in front of your teeth? If you're a tongue thruster, it's probably flowing over those teeth. Okay? Open mouth breathing, again, for the same reasons we just said. It tends to be a habituated pattern. If you have a resisted nasal sinus, throat, any of those things, you're going to have a more open mouth breathing posture. It is very, very common. Now, that doesn't mean every single person who has tongue thrust is an open mouth breather. They're not, but it definitely common characteristics, okay? The other is the reverse swallow, which I call the bullfrog effect. It actually is a hallmark. I have it listed here in common characteristics, but it actually is a diagnostic tool that I use, one of the 3 hallmark factors. So we'll go into that a little bit more when we get there. But the bullfrog effect, and I think I'll probably, because I'm doing these recordings without video, I probably will do a quick snippet that will do a demonstration of a reverse swallow versus a posterior swallow. I tend to do that when I'm in live lecture, and I'll have them do a close-up so that you can see that. So I will try to capture that as well, even though this is a more introductory class. It's really not important for you to know the difference between a reverse swallow and a posterior swallow on a diagnostic level. I just think it's an interesting fact, and if you as an individual with tongue thrust, or a parent or something like that, if you can see it and you know it's happening, you're going to be far and away more empowered and knowledgeable than probably 90% of the professionals that you are interacting with, just because it's very cutting edge. Okay, it's just a way that you can see a reverse swallow without being too invasive. Because again, I'm working with teenagers. They don't want me all up in their mouth, pulling on their lips while they're swallowing. None of us do. Avoidance of chewy or tough foods. I happen to think this comes because they're using the front of their tongue to masticate. That's our fancy word for chew. Okay, so mastication is the chewing, the moving around of the bolus in the oral cavity. Okay, so you're chewing your foods, and a tongue thruster tends to use their tongue a lot against their teeth and moving it around rather than chewing with their molars. Now, is that because they don't have great alignment of their molars or of their canine? So I call them your biters and your chewers. The biters are your front teeth and your chewers are your molars. And you remember those pictures that I showed earlier. If they're having that lateral thrust, then they might not have good contact on their molars. Or I've even seen it where they just have almost like a hole, like they're thrusting through the corner of their teeth rather than the front or the sides. It's still kind of a lateral, but I mean, there's just all sorts of different patterns. But if you don't have great dentition, then, I mean, meaning that the alignment is not really efficient, and your tongue has habituated this other reverse swallow, you oftentimes are avoiding these foods because they're just hard to eat. So I'll have some of these people say, I don't eat meat. And I don't eat meat, it's not because they're just like, I don't like it. I don't like the texture. It's hard. Others might avoid things like carrots or raw apples because they're hard. They might avoid taffy or things that are really chewy for the same reason. So it just depends. It's interesting because they won't realize they're avoiding it until I go through different foods with them, and they'll be like, oh yeah, I don't eat that. And then as we talk a little bit more, it's because it's dry, or it's because it's chewy, or it's because it's tough. An abnormal gag reflex is really super common as well. It can be either hyperactive or diminished, meaning that just even coming at them with a tongue depressor to do a look-see in their mouth, they're posturing and gagging and in anticipation. And then there's the opposite of that, which is I can be in there playing tonsil hockey with the tongue depressor and back on their posterior pharyngeal wall, which is the very, very back of your throat. They don't even know I'm there. So it can be either way, but it's not normal. It's generally either one or the other. And again, it's because it's desensitized. It just doesn't, either they don't use it at all, or it just doesn't even know it's there. Okay. And then choking. I would say, well, it depends on the situation. The choking is less common because generally tongue thrusters are very skilled at their compensatory strategy. The one that's most significant in my mind was a 7-year-old. I generally don't begin the tongue thrust protocol until after the age of 8, for reasons we'll talk about as we're coming up. But this particular phone call from a parent, because this child was at school and choked on spaghetti, and they rushed him to the ER, and they did a video fluoroscopy, and which is an X-ray of the swallow when they're actually doing it, and realized that he had a tongue thrust. So his was a very unique tongue thrust diagnosis because it was diagnosed under X-ray, and he was 7 years old. Generally, it's a clinical diagnosis, and they're older. But because of his choking episode at school on something as simple as spaghetti, it's because he couldn't control that bolus, and he lost control of it because he wasn't doing that up and squeeze back. He was flipping it back. So with a reverse swallow. And very, very often they will use liquids to liquid wash to clear the bolus, meaning that they, especially with dry foods, they can't get it down. They'll have a lot left in their mouth, and they'll have to wash it out to get it all down. They also tend to be a messy eater. They'll tend to have a lot of food left in their mouth, or, again, my poor daughter, throwing her under the bus again. She was a tongue thruster, and so again, maybe it is congenital. She is, and her daughter is. We called her Messy Jessie because she always had this crumbs around her plate, and her dad was constantly on her about closing her mouth. And it's not because she was careless or belligerent or any of those things. That was just it. She pushed it forward to throw it back, and so sometimes it falls out, and that's just the way it is. It is very common that our folks with tongue thrust have orthodontia, and that is because of a malocclusion. So a lot of times they do have an overbite or an underbite. An open bite is probably the most common because that tongue is peeking through somewhere. So it is very common that they are in orthodontia or will be having it. Going along with that is that high vaulted palate, because the roof of the mouth, and when you look in a mouth, which we do a lot as speech language pathologists, the palate is a nice dome, and it's generally smooth. Well, in tongue thrusters, the palate is generally very, very high, very narrow, very deep, and along the front teeth, you have ridges. And again, with someone who has a typically developing palate and rugae, it's all kind of smoothed out because that's where the tongue rests. So it just kind of carves it down, smooths it out. But with a tongue thruster, it tends to be very vaulted, very defined, very high and narrow, and they will have sharply defined rugae. So I refer to it like the sawtooths. They're just really, really sharp and defined, as opposed to being like smooth foothills. Okay. You can probably tell I'm from Idaho with the foothills and the sawtooths. So sorry about that reference for those of you somewhere else in the world who have no idea what I'm talking about. The sawtooths are a very rugged set of mountains here locally. I mentioned this earlier on when we were talking about kind of the history of tongue thrust and the controversy. The articulation errors that are very common with tongue thrusters are that frontal or lateral lisp. the residual R, and the fronting. So any of those sounds that have been misarticulated because they've moved past the front teeth, those are generally associated with tongue thrusting. There is generally a significant difference in the anterior tongue strength and the range of motion compared to the posterior and even lateral. Okay, what that means in layman's terms is that the front of their tongue is far more coordinated and strong than the back or even the sides. And again, that's because they use it for everything. They use it for their articulation, they use it for their resting, and they use it for their swallowing. And so the back of their tongue just kind of sits there and hangs out because it's attached, but it doesn't really do much. So there is definitely a difference there. All right, this is another great place for us to take a break. I'm going to shut her down, pick up with the clinical solutions related to tongue thrust. Now that we've talked about the dilemmas, we can talk about the solutions and what we're going to do about it.